Hello everyone, good afternoon. My name is Dr. Edgar Gonzalez. I am an oral surgeon and implantologist from Dominican Republic with a clinical and academic focus on implant dentistry and digital workflows. I'm also passionate about teaching and continuous education, and today we will be sharing two clinical cases focused on aesthetic parameters in the anterior maxilla, which we know that sometimes can be the hardest cases. But before that, I would like to briefly discuss the three key parameters that we take into account in our daily practice to achieve successful outcomes in implant placement in the aesthetic zone. The key parameter number one is the three-dimensional position of the implant. That is one of the most critical factors for achieving long-term aesthetic success in the anterior maxilla. Proper mesiodistal, apicocoronal, and buccal palatal position allow for adequate hard and soft tissue support, facilitates the development of a natural emergency profile, and reduce the risk of recession or implant exposure. An incorrect three-dimensional position is often difficult or even impossible to compensate with prosthetic or soft tissue procedures, and the correct three-dimensional implant position provides biological stability, prosthetic flexibility, and predictable aesthetic results. The key parameter number two is the soft tissue management. We know that the soft tissue management plays a fundamental role in achieving stable and predictable aesthetic outcomes in the anterior maxilla. The quality, thickness, and volume of the soft tissue directly influence the final emergence profile, the stability of the gingival margin, and the long-term aesthetic result. A thin soft tissue phenotype is associated with a higher risk of recession and tissue collapse. For this reason, soft tissue augmentation should be considered when necessary to increase tissue thickness and improve long-term stability. Proper soft tissue healing combined with correct implant position and provisionalization allows us to give tissue healings and create a natural, harmonious peri-implant architecture. Now our key parameter number three is the bone management. Management is a critical factor to achieving long-term stability and aesthetic success in the anterior maxilla. Adequate bone volume, especially at the buccal aspect, is essential to support both the implant and the overlying soft tissue. Insufficient buccal bone thickness is strongly associated with soft tissue recession and aesthetic compromise. For this reason, guide bone regeneration plays a key role in aesthetic implant cases. Bone reconstruction allows us to restore lost volume, create a stable foundation for implant placement, and support soft tissue architecture over time. When bone regeneration is properly planned and executed, is significantly improve the predictability and longevity of aesthetic outcomes. Selecting the ideal grafting material with appropriate biological properties is essential for predictable bone regeneration. The graft must be provide adequate volume stability and support for the implant and overlying soft tissues. Choosing the appropriate membrane is a crucial step to properly isolate the graft area and prevent soft tissue invasion. Proper graft and membrane selection directly influence the quality, stability, and longevity of the regenerated bone. Successful bone regeneration is the result of proper material selection, biological principles, and precise surgical execution. And now we have our first clinical case. that involved a 20 years old female patient who presented to our clinic with a fracture of tooth number 11, the maxillary right central incisor. Due to her young age, the patient expressed significant anxiety regarding the treatment. For this reason, the procedure was performed under conscious sedation, and our objective was to complete as much as the treatment as possible in a single surgical intervention. In this picture, we can see a thin gingival phenotype, and we can appreciate the fracture. During the 3D planning of this case, we observed that implant placement in an ideal prosthetically driven position was feasible with adequate overall bone availability. However, we also identify a partially collapsed and very thin buccal bone plate, which could further compromise the situation during tooth extraction. It is important to note that the tooth had previous endodontic treatment and a post in place, which further complicate the extraction maneuvers. For this reason, a treatment plan was designed taking these critical aspects into consideration. Our treatment plan was first, minimally invasive tooth extraction, immediate implant placement, connective tissue graft, guide bone regeneration, and immediately provisionalization. We began with a minimally invasive extraction, carefully preserving the surrounding tissues of the alveolus, which is a key factor for the final success on the procedure at this stage. Then the surgical guide was positioned to perform biological driven drill through the guide. Connect seating and stability of the guide were verified before initially the drilling. After completing the drilling, a connective tissue graft harvested from the palate was placed to increase both the quality and quantity of the buccal soft tissue. Then a collagen membrane was positioned to isolate the soft tissue and protect the bone graft placed on the buccal aspect. As demonstrated in multiple scientific publications, support this technique. Predictable outcomes cannot be achieved unless the soft tissue is properly isolated using a membrane. Additionally, a 360-degree connective tissue graft was incorporated around the provisional restoration to further reinforce the soft tissue, not only in the buccal aspect, but circumferentially allow to the development of an optimal emergence profile. And finally, an immediate provisional restoration was placed along with coronal suspension sutures to help maintain the soft tissue in a stable and favorable position. These sutures were scheduled to be removed at 15 days post-op. This slide shows the clinical outcome at 6 months post-op. At this point, please note the thickness of the keratin tissue. It looks pretty well. Now, returning to the initial situation, but from an occlusal perspective, we can clearly observe the collapse of the buccal bone plate. This confirms what we had already been anticipated during the digital planning phase. There was a clear need to reconstruct the buccal bone plate and perform soft tissue grafting in order to increase tissue thickness. The surgical guide was designed with a specific opening to allow for connective tissue graft harvesting using an intraoral desepitalization technique. With these measurements previously established during the 3D planning and risk of injury to the palatine artery was eliminated, allowed us to proceed with a greater safety and confidence. Biological drilling was performed, allowing for a proper preparation of the implant size. We can see the palatal approach in the picture. Then the connective tissue graft and resorbable membrane was positioned and established with suture. First, we suture the connective tissue graft and then the membrane. A 3.5 by 11.5 millimeters IS3 implant for Nobiotech was placed, achieving an insertion torque of 45 Newton. In this image, we can observe all components in the correct position: the connective tissue graft, the resorbable membrane, the implant, and the buccal bone reconstruction. The palatal is sutured too. Here is a clinical view at 7 days post-op. At this stage, we can observe rapid healing in just 7 days post-op. At this appointment, only the palatal suture were removed. And here a clinical view at 6 months post-op. Please note the three-dimensional thickness of the soft tissue. In the image on the right, the implant is correctly positioned along with proper bone reconstruction, as you can see. And now this is a video of the procedure where we can observe a fast motion summary of the surgical workflow. An incision with a microblade was performed to create the necessary space for guided bone regeneration and connective tissue graft. Then the surgical guide was positioned and drilling was carried out through the guide from a palatal approach. And now the connective tissue graft was harvested with a predefined safety margin established during digital planning and suture to the buccal aspect. A resorbable membrane was fixed, followed by placement on the bone graft with the sockets. As you can see in the video. At this stage, we are carefully packing the bone graft, ensuring it covers the entire extent of the socket without applying excessive pressure. We are continuing packing the bone graft. Doesn't matter, we have to close the alveolar zone, packing the bone. And after that, the surgical guide was then repositioned, and the final 2 drills were used to complete the biological drilling sequence. As you can see, this approach allowed for bone compaction and improved insertion torque during implant placement. At this stage, the implant was placed, following by immediate provisionalization. Here you can see the components, the provisional tooth. And after the provisionalization, we finally proceed with suturing, as you can see now. Okay guys, the second clinical case involved a 30-year-old male patient who came to the clinic wearing a removable prosthesis to replace the missing tooth. The maxillary left central incisor had been extracted by approximately 20 years prior, which resulted in a significant collapse of both hard and soft tissue in the area. Another view where we can appreciate the collapse of the buccal plate, and an occlusal view. As you can see, we can appreciate the collapse too. During the digital planning phase, we observed that implant placement in a correct prosthetically driven position was feasible. However, adequate management of both hard and soft tissue needed to be incorporated into the treatment plan. Here we verify the proper seating and stability of the surgical guide, and full thickness flap was elevated, and an immediate collapse of the buccal bone plate was clearly evident. Following biological drilling, the implant was placed through the surgical guide, achieving correct three-dimensional position, the key parameter number 1. As we can see, the implant was positioned correctly. However, a large buccal fenestration was present, which required surgical treatment. And was the next step: selection of the graffiti material for the defect reconstruction. In this case, an immediate provisionalization restoration was placed, carefully respecting the critical and subcritical contours to allow for the development of a proper emergence profile. And a first graft was performed using autogenous bone harvested from the external oblique ridge. The autogenous bone graft was selected due to its superior biological response and integration with the dental implant, in addition to its osteogenic, osteoinductive, and osteoconductive properties. The graft was placed using the sausage technique, and the membrane was established on the buccal aspect with fixation pins. An autogenous bone graft was harvested using this bone scraper. And now, as you can see in the video, this is the scraping motion we use to harvest the bone. This is not the same clinical case, but is shown here for a demonstration purpose. A second graft fitting procedure was carried out using a demineralized allograft to preserve and change buccal volume. Bone allografts are primarily osteoconductive and may present osteoinductive properties depending on their processing, although they are not osteogenic. This result in improved contour, as demonstrated by the comparison between the pre-op and post-op CBCT image on the right side. Then we did a secondary stabilization of the membrane using sutures. You can see the pins fixation in these pictures too. And now the fixation of the connective tissue graft on the buccal aspect to further enhance soft tissue volume and quality. Here we have the immediate post-op clinical and tomographic image. Here you can see the clinical evaluation at 7 days post-op, and clinical evaluation 15 days post-op. Suture removal was performed at this stage. And finally, 6 months post-op outcome. Please note the adequate emergence profile and the volume achieved in the treat area. It looks so pretty. And now here you can see a comparison between the initial condition and the final outcome. And now I would like to sincerely thank Gao and Neobiotech for the opportunity to share my clinical workflow. These outcomes are only possible through a multidisciplinary approach, and I am really grateful to be part of a team that continues looking for excellence in implant dentistry. Thank you very much.